From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello and welcome to our listeners around the world. You're listening to JAMA Dermatology Author Interviews. Thanks for joining us. I'm Dr. Adamson, the web editor for JAMA Dermatology. Stevens-Johnson syndrome / toxic epidermal necrolysis, also known as SJS-TEN, are rare, life-threatening, drug-induced severe cutaneous adverse reactions. Beyond acute morbidity and mortality, SJS-TEN can cause visual impairment, blindness, and long-term effects impacting functioning and quality of life. While research on physical symptoms experienced during acute hospitalization is well documented, there are limited studies on the long-term biopsychosocial effects of SJS-TEN, particularly from the patient perspective. In a new study in JAMA Dermatology, authors aim to study the long-term complications in patients caused by SJS-TEN. Dr. Elizabeth Phillips is a professor of medicine and dermatology and director of the Center for Drug Safety and Immunology, as well as the John A. Oates Chair of Clinical Research at Vanderbilt University Medical Center in Nashville, Tennessee. She's the corresponding author of this new study and here to discuss this important and impactful work. Welcome to the podcast, Dr. Phillips.
Thanks so much. I'm pleased to be here.
And I'm very happy to discuss this really important topic. There aren't a lot of qualitative research manuscripts that look at complications related to patients with this really rare but very serious dermatologic outcome. Now, before we launch into the study, I want to know a little bit about you and what you do at Vanderbilt. I know you're not a dermatologist. You're, in fact, an internal medicine physician and infectious disease doctor, if I'm not mistaken.
That's correct. But my clinical and research focus is actually seeing patients both in the acute and recovery phase that have severe cutaneous adverse reactions. That's something I've been doing for over 30 years and actually evolved from the fact, actually involved when I was an infectious disease physician training in Toronto and then trained in clinical pharmacology in Toronto. It became very clear that patients living with HIV that were being treated with all sorts of multiple drug regimens were totally out of control and had many different adverse reactions. So that was really my entree into that. And fortunately, at least in the United States and most of the developed world now, we have tolerable regimens for HIV. So HIV patients are not at the center of these types of terrible reactions, but it kind of evolved into, I guess, a lifelong quest to find answers and make life better for patients, both in terms of prediction and prevention of these types of reactions. But in the recovery phase, it became very clear that they just went off the radar. They, what happened to them? They were often not being seen by physicians or medical providers in the recovery phase of their illness.
And so because this disorder is quite rare, you really have to develop a cohort of patients. And for our listeners that may not know, can you describe that cohort that you've been involved in developing and growing over many, many years? How did that come about? And is it multi-center or is it mostly just at Vanderbilt?
Well, so the concept for this particular study, we do have a prospective study that we've been biobanking patients that could get referred to Vanderbilt. But this particular study grew out of something called the SJS Survivor Study. And what I had noticed was that patients who get SJS, they often are fearful of drugs in the medical system. They often don't return to work. They don't have insurance. So they're not as likely to show up, even for studies that are being attached to medical centers. So the concept of this was to do a cross-sectional study where we actually reached out through social media and the web to try and get survivors engaged in studies, not dependent on them being actively engaged in medical care. And that was the concept of that, to find out what was happening with them in the recovery phase and the adaptation phase of their illness. And also it formed the basis of a genetic study as well. So we could try and look at what risk factors were driving these terrible drug-induced reactions and whether those risk factors were the same in the United States as has been described in some other countries.
But for the sake of this specific paper, you were really concerned from a qualitative perspective, the experience of long-term survivors of SJS-TEN. So you queried the SJS survivor study to look for patients that were willing to talk to you about their long-term experience after having received and recovered from SJS-TEN. And, maybe recovered from is not quite exactly the correct term because of long-term consequences that they have had to continue to deal with. But how did you go about consenting people to talk about this really traumatic experience that they went through as patients with this disorder?
So we had enrolled patients into the SJS survivors study, and we had planned, based on a sort of rough sample size assessment, to get approximately 30 survivors to participate in the qualitative study. And we wanted there to be good representation across sex and race. And so we actually did not do this randomly. We were trying to pick from our group and sort of get as broad a representation as possible. And we also, in the midst of doing that, use social media techniques in the middle of this to try and recruit patients into the study, just the broad study, the overall study, that would actually not necessarily attract certain groups over others. And so we were very committed to try and get a broad range, variety of individuals so we could understand what the drivers are of recovery, adaptation, and the lived experience of the patient.
So going into this study, after you put together your interview guide that you then used to do these semi-structured interviews with the survivors, what did you think before doing this study you were going to find? Were there certain patterns or themes that you thought, okay, I know that this is going to come up? And were there some things that surprised you about what came up?
Yeah, so I think the basis for this, and maybe the concept for it, and why this was actually a grant that was funded by the NIH, by the NHGRI. And leading into this, we'd had several meetings where we actually brought together survivors and members of the scientific community together to have basically to share scientific content and to share ideas from basically advocacy groups and survivors. And so a number of themes had emerged from these early meetings in 2017 and 2019 that formed the basis for the ideas that it was going to be important to look at recovery and the lived experience of the patient across as broad a range of demographics as possible. And so that was how that became written into the grant. And we collaborated with our qualitative and behavioral sciences core at Vanderbilt that has a lot of experience doing this across a lot of disease states, but had not had as much experience doing it across rare diseases. So this was something that evolved over time. I think we had some concept of what we might be finding based on the very candid interactions that we'd had with patients based on these in-person meetings that had been held in 2017 and 2019 before the concept of the study arose and the grant was written. And so that's how it evolved.
What I find fascinating about the results of your work is you describe how SJS-TEN survivors go through these three distinct stages of, acute, recovery, and adaptation. You mind taking the listeners through that kind of process of how you think about it? And then after that, we can talk about some of the kind of pointed quotes that you drew from some of these survivors of SJS-TEN.
Yeah, so this is part of the defining, I guess, biopsychosocial framework of SJS. And if you think about it, and this study exemplifies this. Most of these survivors actually had SJS within the last 10 years, like 2/3 of them, at a prime time of their life. So in their 20s and 30s. And it came as just out of the blue, an unanticipated event out of the blue. And most patients, when they get SJS-TN, if they're put into appropriate care, they end up being transported sometimes hundreds of miles away from where they live. So imagine you take a drug, a couple of weeks later or a few days later, your body breaks out in this terrible blistering rash and you feel terrible. And then you are airlifted away from all of your support systems to somewhere you don't even know. And you're there for a month. And then you're discharged back to your community, but no one really understands what happened to you or is prepared to counsel you on what has happened or even what drugs that you can safely take in the future. And so this was, I guess, a lot of the motivation for doing this was it's like a incredibly destabilizing situation. And some of the things we see acutely in the acute phase when patients are in hospital, they often don't have family members there, sometimes for a couple of days. So they're literally isolated there. They go through this incredibly traumatic experience. Well, I mean, with exemplary care often for,
Some of them in the ICU too.
and it's in the ICU or the burn unit, which is the equivalent of the ICU. And then they are discharged back and it's very disorienting because many of these individuals had nothing wrong with them before this happened. And they were taking, the majority of patients that we interviewed were taking common antibiotics. So not, esoteric drugs, just things that you would take for a skin infection or a urinary tract infection. And they were otherwise healthy on no medications without pre-existing medical problems. So you can imagine in that situation how that is, and then to kind of land back in your community where no one or few providers have ever seen the disease that you've just been through for 4 weeks. There's a lot that we've gleaned from this, just outside of the formal qualitative assessments in these patients is the number one thing that patients will say in the recovery phase is that they don't have providers who know what to do.
But sometimes the challenge is also, this is more than just a skin disorder.
Right.
People have issues related to their eyesight,
Right.
as well.
One of the big things is loss of control and loss of autonomy. This was one of the big themes that came through in these survivors. And, there's one survivor, if I can quote this, and this is in the manuscript, said, "I have no quality of life right now. I can't drive anymore because of my eyesight and my seizures. I'm not even 60, and I have to depend on people everywhere I go. And that bothers me because I've been very independent all of my life." And, this is kind of exemplifies that lack of, and this woman was coded as being in an adaptation phase because she was several years following the acute phase. She'd adapted, but she had adapted to a very different life than she had been used to before this lightning had struck, basically.
Yeah, and some people would even slip into depression after the acute phase of the disorder into the recovery phase.
Right. I mean, I think that's an important point because an important point from patients is that they're not put into multidisciplinary care and they don't necessarily get mental health assessment. And one of the comments in the paper from a survivor, a quote in the paper was, "Do I think that I should have had a mandatory referral to someone for my mental health?" And it was absolutely, I think that everyone needs to do this and it should be normal practice. And the frustration from this particular survivor was feeling that they had to be an advocate for every aspect of their health, including their mental health, when they were at a vulnerable stage and they couldn't really put everything together.
And currently, are there guidelines as to what should happen, at discharge or during the adaptation phase or recovery phase in SJS/TEN? And do you think that, if not, that we should come up with some kind of guideline?
I mean, there's healthy exercises and consensus that post-discharge care should be prioritized for patients. And there's sort of a checklist and a roadmap, if you will, of what that should comprise. And those articles have come out over the last few years. And I think this is hugely important. And the question is, how do you implement that? And the issue is if that doesn't get implemented at the time of discharge, then it feels like it's a runaway train. It feels like you're sending the patient out in the community and they don't have the supports that they need. So, patients are often very laudatory about the acute care that they've had. They're obviously very grateful. They're really getting a lot of exemplary care and attention and the supportive and critical care they need during the acute time. But it's really that transition that seems to be the challenge. And I think it's a question of, when you have a patient that's several hundred miles away from where they live, how, the challenges of trying to get someone like that into multidisciplinary care when there are few providers across the United States that are actually able to do that. So vision loss and impairment is a huge risk in these patients, and up to 80% of patients have acute visual problems that transition into chronic visual problems. But even finding an eye specialist that can deal with this is very challenging.
Yeah, and one quote that stood out to me was this feeling of abandonment, where a participant said, I was abandoned. I literally don't have any friends anymore. Everybody just sort of disappeared. It was when I was really sick, everybody was checking with my daughter. And then once I got out of the hospital, it was like poof, everybody was gone. I mean, that's devastating. But it also begs the question of, for such a rare disorder, how can we come up with ways to support these people, right? There are not many of them, and they're dispersed across a large area. And do we need some type of, centralized intervention that maybe is remote, that can kind of help folks coordinate some of the care that they may need? I'm just asking the question. I'm not sure what the answer, or if there's an easy answer.
Yeah, I think there needs to be structured care and pathways for these patients that actually are put into place during the very early discharge planning phase. And there needs to be a network across the United States of providers that can work together on this. There are advocacy groups, and they have been extremely helpful in fighting for this cause. And they also are very passionate about the issue of post-discharge care, because many of them are SJS survivors themselves and have had to really fight that battle.
So I know qualitative work often have a lot of deeply personal kind of impact on folks that are doing the work, because you get a very intimate look into somebody's lived experience. Do you feel as though this work that you did, this specific paper, has given you a better appreciation of what patients are going through? And then, and if so, how do you think this kind of changes the way you may approach this disorder, or what's next?
Yeah, I think this was very interesting and had a deep impact on me, because we had already spent in these meetings with the community hours, listening to community members and having some concept of this. But I guess what was so revealing is the extent to which they feel abandoned on every axis. As you identified, they're losing their social network, their vocational network. Many of them are not returning to work, and few of them actually return to work. In one study, less than 20% of them returned to work during the first year. And they've also not got a robust network for mental and physical health. So they're really, the extent to which they're unsupported was really, I think, deeply hit me. And there's one quote that really struck me as really hard, because the issue of drug safety and, patients being fearful of drugs to the point that they avoid all drugs, even if they're distinctly necessary, is really hard to take, and it seems inhumane, right? You can imagine
That's a
undergoing
great point.
procedures without anesthetic, avoiding basic medications for fevers and pain. And one quote was regarding this was that one survivor had said that one piece of advice that her provider had given her when she said she was fearful to take Tylenol was kind of a get back on the horse type argument. If you're in a car accident, do you ever get in the car again? And the survivor didn't feel she was in a state that she could actually do that. So it was, the question of how do you get off the hurdle? And you can imagine if you're left and you're unleashed out in the community, and the issues regarding drug safety are not dealt with very early and very definitively, and years later, you're just going to want to avoid everything. And how do you broach that? It's something that has to happen very early. There needs to be counseling and the process needs to start in the hospital, even though there's a lot of acute issues that are being dealt with. So to address your earlier question about what can be done, I think, and there is some data to support this, that starting the process in hospital and starting the support, the multidisciplinary support, including mental health in hospital, is very important. Counseling on drug safety in hospital and then transitioning smoothly into the community so that there is not that feeling of abandonment. And so I think starting the process, it seems, we don't like to do things when we think we don't have patients' attention or that there's too many things going on, but it's hugely important to start that process in the hospital and to spend time.
Dr. Phillips, I want to thank you for coming on the podcast. I'm Dr. Adamson, web editor for JAMA Dermatology, and I've been speaking with Dr. Phillips about the long-term complications in patients caused by SJS/TEN. You can find a link to the paper in this episode's description. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening. Catch you on the next episode of the JAMA Dermatology podcast.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.